Assalamu alaikum wa rahmatullah, dear colleagues. Uh, Hi, everybody. We'll start now the surgical retina session of quick program. We made a slight change. We're going to start with Professor Dr. Saad Wahib with his slide. And Dr. Ahmed Al-Khashab will move last, inshallah. So, Dr. Saad, can you share your screen with us?
Sure.
Dr. Saad is going to talk about the silicone oil tamponade and complex retinal detachment.
It's a great pleasure to be part of this meeting. I'd like to thank the organization for giving me this wonderful opportunity. As you have seen with the previous wonderful speech and great speakers that we're talking about complex retinal detachment, I thought along the line I'd like to talk about a very important tool, but the very physical properties to silicone that allows it to be a great intraocular tamponade, but the two most important ones are the specific gravity and the viscosity. The viscosity is the ability of the oil droplets to stick together and form one single droplet, which is very useful in its use as intraocular tamponade, as well as its specific gravity being less than water, so it will float. And that's why you have to have a good fill when you're doing silicone. Now, we went through the indication in the previous speech, as I said, but mainly I'm just going to go through them. The complicated retinal detachment with PVR, specifically acute retinal detachment, oculotroma, giant retinal tears, choroidal chromoma associated retinal detachment, and finally diabetics, whether it's a tractional or a combined tractional rhegmatogenous detachment. Silicone oil can also, as we said previously, be used in patients who have to travel immediately post-op or patients who have difficulty in positioning. So we can use it for simple cases, but for now, that's an important slide that I'd like to draw your attention to. And this is something that we commonly see in practice. There's a different surface tension of the different material stuff that we use in oil. And I'll give you the scenario which we commonly see. You do a complex retinal detachment with inferior PVR, and you do a vitrectomy, you remove the membranes, you take all the subretinal bands, and then on the table, you do airflow exchange, everything looks fine. And then when you put silicone oil next day, it is an inferior detachment. What you forget is that when you're doing airflow exchange, the airflow exchange surface tension is around 70 or 72 dynes per centimeters, while when you're doing silicone oil, the surface tension of silicone oil is only 40 or 42 dyne per centimeter. So there's a 50% reduction in surface tension. So the ability of the air fluid to push the retina is 50% more than oil. And that's why you want to make sure to remove all the membranes. And that's why some surgeons actually advise that if you have a redetachment under oil to finish or to do the surgery under oil, what I usually do is I remove the oil and I do the surgery and I put oil again. But some surgeons advise to do that under oil because of this property. You lose a lot of surface tension when you put oil. So unless you have a good you've done good surgery on your room membranes, and that's why sometimes the idea of using silicone oil can give you a false sense of security that you don't commonly see. Now, I wanted to share with you some of the important practices. I think are very practical points in using silicone oil. You know, the step of installation. What's the ideal filling? Is there any special situations? The duration and the cover, and finally the removal. So let me just go. When you're installing silicone oil, there are different ways of doing that. You can just do airflow exchange and then put silicone, or you can do direct PFO silicone exchange, for example, in cases of giant retinal tears when you're worried about slippage. The whole idea is to be in the right meniscus. So if you're doing airflow exchange, you stay in the fluid until you have good airflow. If you're doing PFO silicone exchange, you want to stay in the PFO, otherwise you get blockage, and that's what you want to do. You want to make sure you go, you finish, you are in the right meniscus with your back flush. or with your infusion, sorry, with your vitrectomy. Now, a few practical points. I'm just going to advance this with you to where I wanted to be. This is removing PFC. This is a bad case, complicated, traumatic case with infused detachment and high female and desiccated eye well. So, you know, you lower the air pressure, you watch the eye, you want to make sure you're watching the eye digitally, and I do silicone oil under that to make sure you're seeing the oil as it fills the eye. And as you do that, you want to allow the air to vent from the eye, otherwise you immediately get a very big rise in the intraocular pressure, and you visually evaluate the filling. Now, what's an ideal fill? An ideal fill is a normal intraocular pressure. So you want to achieve good tamponade with good fill of silicone oil without having a very high intraocular pressure, because if you underfill the oil, we spoke about self-retention, you lose the benefit of the tamponade, and if you overfill the oil, you get into all the complications of increased intraocular pressure and glaucoma and corneal decompensation, and that's an interesting case. This is a patient who had an inferior retinal detachment with PVR and demarcation line going through the just under the fovea and a macular hole. So I'm just going to skip the actual surgery, and I'll show you at the end. Again, same thing when you're doing the after you're doing the air fluid exchange, you're doing it fat, and then you fill up the eye with oil, and again you want to do that under direct supervision. Okay, and after you do that, you evaluate the intraocular pressure, and you fill the eye with oil after you venting the. Now, is there any special situations? Yes, there are some special, for example, in aphakia. The problem of the challenges they see is that if you have an aphakia the silicone bubble tends to come. I have seen last week a case that I've done myself, a patient with the Yamani technique, and she developed vitreous hemorrhage. She's diabetic. We had to go back and do a vitrectomy, and we had to put silicone oil in this lady, and then oil came into the anterior chamber. There was an actual lens, but it was the Yamani technique, so there was actually no capsular support. So the oil does migrate, despite the fact that it tends to remain in a single bubble, but it sometimes migrates. And of course, if it migrates, then you run the risk of glaucoma and corneal decompensation. And that's why, the people have used different techniques. You can leave the eye with air, you can put air in the AC, sometimes they put a suture, and the whole idea is to try to keep the oil away from the anterior chamber. Now, what happens if you get oil in the anterior chamber? I think it's time to remove it, because if you try to remove the oil only from the anterior chamber, the oil will keep on coming and you end up with. How long would you keep the oil? It's chemically inert, and but it's temporary, so you can keep it as long as there is no complications. There has been some reports of unexplained visual loss after insulin oil, accompanied by loss of the foveal depression and scotomas and macro. Most surgeons would remove oil between 3 to 6 months, so most of the times we use 1000 centistoke. If you develop any of the complications, specifically the emulsification, which gives you the classic inverted hypobia, then it's time to remove the oil. But every time I remove the oil, I sit with the patient and I tell them about the reported risk of redetachment of up to 20. So now finally, removing oil, there are different ways of removing oil. You can do it blindly, just by 2 ports, and definitely a lot of surgeons advocate that. I personally like to see it as I remove it, and the classic technique popularized by Mandukon, which is the soap and sandwich. You do multiple air fluid exchange. Now, some people claim that no matter how many air fluid exchange you do, you will always, unfortunately, have oil droplets. But I think you do your best, and after you remove it, you can see the meniscus here in the video. You go back to the back of the eye, and most likely you can see some bubbles, like in this case, some remaining. I think these are PFC bubbles, actually. And then you do multiple air fluid exchange to try it.
Okay, I think I'm going to stop at this because of the time.
Okay. Thank you, Dr. Saad. Thank you for this nice presentation. It was very informative about silicone oil tamponade. I guess we'll keep the questions till the end of the session, and now we'll move on to Professor Dr. Faisal Fayyad. Dr. Faisal Fayyad, please, would you share your screen with us?
Yes.
The topic is about globe laceration with choroidal and retinal detachment.
This is my presentation. Actually, I was informed that the presentation is just 3 minutes and 6 minutes discussion. And that's why I'm just presenting a 3 minutes presentation according to the program. My presentation is global laceration with choroidal and retinal detachment. I'm presenting a single video. This patient had penetrating trauma at presentation. This is the picture. He hardly could see light perception, even, sorry, I have to go back. Light perception was query. There was choroidal hemorrhagic choroidal detachment with total retinal detachment. And this is, I'm draining the choroid. You can see very well. Blood is coming out. And here I went inside the eye, and this is the picture how the retina looks like. This is organized vitreous, you can see there. And there is total retinal detachment. I was just exploring what could I do then. And this is how the retina looks like. I could not see where is the posterior pole. And suddenly I was lucky to find a retinal break posteriorly. Here I am aspirating this retinal fluid through this retinal break. And once I aspirated, finally, I could see the optic disc. There is retinal incarceration. What that means that those folds are sign of retinal incarceration posteriorly. This area is a diffuse chororetinal scar temporally. I decided to do lensectomy at that point in order to avoid any anterior proliferation. And here I'm draining what is left from the choroidal detachment by elevating the trocar and moving the infusion into the anterior chamber. Here, this is the huge scar, chororetinal scar, a lot of blood inside the eye. The infusion is back in place. Decided to do retinectomy where the retina was incarcerated up to the aura, cleaning the subretinal space from the blood by elevating the retina with the back flush needle and cleaning with the other hand. And finally, I got the retina flat. I did direct exchange in these cases. I prefer to do direct exchange. And the retina is flat. 2 or 3 months later, I went inside the eye, the retina completely flat, but really I missed peeling the internal limiting membrane, and I was punished for that. And there was, as you see, the retina is completely flat. This is my case presentation, and this is it.
Thank you, Dr. Faisal, for a very nice presentation and surgery. And we might have some comments from the panel. We finished early this presentation. We may link the Dr. Saad presentation about silicone oil tamponade. So my understanding, Dr. Faisal, you left the patient on silicone, right?
And yes, of course.
What about the is silicone 1,000 to 5,000? Doesn't make any difference in such
case? You know, once there is high probability of PVR, usually I prefer to leave the patient under 1,000 cystoscopes. In this case, it was 1,000 cystoscope silicone oil. But well, it's not very fast. This is what I mean. This is because discussion was for 6 minutes and 3 minutes presentation. And I rather to present something and discuss it with my colleagues. rather than
I think
showing.
discussion is the best thing. Good morning to everyone. Dr.
Good morning.
Dr. Abdullah, Dr. Faisal, Saad, and Talwar.
Dr. Saad, would you prefer doing the same silicone oil 1000, 5000 in such a case? I'm trying just to link things together, presentations. So it's a complex case, post-traumatic.
Yes,
And
I guess the decision depends on the surgeon preference and also depends on the case. Generally speaking, we like to use 1000 because most of the times we don't leave silicone more than 3 to 4 months. But I think, if you think this case might take longer, or if you're planning to leave it longer, 5000 will probably a better choice in form of complications. The possible.
Any
Yes,
comments from Dr. Salam or Dr.
I would agree. I would agree, except, after 4 hours surgery, I rather to do it quickly. I mean, to inject 5000, it is going to take a long time or longer time. 1000, it takes 2 minutes, after
5000 will take 10 minutes. 10 minutes will look too long at that time.
Absolutely, even 5 minutes.
Actually, I think, really, frankly speaking, I find no significant difference in the rate of emulsification. So minimal difference, and it's much more difficult to put in and remove. And, you have to remove it anyway. I mean, I'm not thinking of leaving that forever. If I was thinking of leaving silicone oil forever, I might think of 5000. And 5000 is more difficult to handle. If you do an overfill, you will definitely get a glaucoma. So you have to be very careful when you're using 5000. So as a rule, I prefer 1000 and I use it routinely. I do not go for 5000 as a rule.
So we may reach a consensus that yes, that there is a method or something like that, that the more complex the case, so you have to inject like 5000.
No, not so.
It's this is not the case. So this is a message to the young surgeons that if you did your job and removed all the vitreous and you just doesn't make a great difference to put 1000 to 5000. 1000 is easier to install and remove. And
it's just giving some kind of a false security. I see the younger generation of surgeons has that feeling that 5000 somehow gives them more protection. Right. It doesn't. There is no difference.
Of course not.
Exactly.
It's a tamponade, nothing more.
Yes.
It's a tamponade, nothing more than a tamponade. Really, where
Dr.
are you?
Salam, do you have a comment?
Yes, thank you so much. And I enjoyed Dr. Saad and Dr. Faisal's presentation so much. I just want to say, I think this comes from the car industry. If you use the 20,000 oil, you feel you can leave it longer, right? But actually the truth is, the differences between 1000 and 5000 are more on the theoretical level, because the main factors governing emulsification are the movements of the eye and intraocular inflammation. Then read the 1000, 5000 centistrokes. It doesn't make a lot of difference, in my opinion. So I always like to keep things simple, and I use 1000.
Can I, Dr. Abdullah, can I just add one last comment here?
Sure.
I think the main point here is to do a good surgery. I think you want to make sure you remove all the vitreous, all the membranes. And I think if you do that, more than likely, you may not actually even need to use silicone. I am not talking about Dr. Fayyad's case, because he had a very tough case. But I'm saying, and that's what I said, I think it's important for people to understand that silicone does not protect you if you don't do a good surgery.
Right. This is the exact message we need to confer to the audience. Guess we'll move now to Dr. Dinesh Talwar presentation. Dr. Talwar is a senior consultant, eye specialist, and vitreoretinal surgeon, Apollo Hospitals, New Delhi. Would you please, Dr. Talwar, to share your screen with us?
Yeah.
Dr. Talwar is going to talk about retinectomy in complex retinal detachment. So we are still in complex cases with the retinal detachment.
This is a 3-minute presentation, so it has to be very quick according to your.
We have a fruitful discussion afterwards.
Yes. So when do you do a retinectomy? The two major situations. One is for access to the subretinal space, which you may do for subretinal membrane removal, only if they're preventing settling of the retina, or you may do it for removal of subretinal blood or subretinal silicone oil, as was in the previous case. The other indication is when you do a retinectomy for retinal shortening. And there are two types of retinal shortening. One is what I call a true retinal shortening, which is when you find an inability to settle retina after you removed all the retinal tractional membranes, and there are no subretinal membranes causing any traction.
I tried to put all my thoughts of how. I'm sorry, I apologize.
Sorry?
Safely and efficiently. Sorry.
Sorry.
So let's get started. Paracentesis, peripheral as you can, out of opening the conjunctiva.
I
apologize.
Is there a problem?
No, it's my problem. I'm sorry.
Okay.
Sorted.
Yeah. So
Go ahead, Dr.
Yeah. So one situation is what I call a true retinal shortening, where there's an inability to settle retina after removing all retinal tractional membranes, and there are no subretinal membranes causing traction either. The second one is where there is a very sticky membrane which cannot be separated from the retina, and this could be localized, as you saw in the previous case where there was an incarceration, or there is a generalized widespread shortening. Now, when there are subretinal membranes, you only do surgery for retinal excess if they are involving, either they're involving the macular area, or if they are mid-peripheral or peripheral, but they are preventing retinal reattachment, which you will see as stenting of the retina when you put PFCL. So how do you remove that? Make sure you remove all epiretinal membranes first. There shouldn't be any epiretinal membranes. For localized membranes, a localized retinotomy is adequate, but for extensive membranes, you may need to do a peripheral retinectomy for access. Now, what you see over here is a patient in whom there's a vitreoscheisis, and you can see there is a membrane which is covering the entire retinal surface. And this was removed. And after this is removed, a vitrectomy is done, a complete vitrectomy, removing all epiretinal membranes. And then you see these subretinal membranes are there. And it was felt that these will prevent settling of the retina. And so after putting PFCL, completing the peripheral removal of membranes, this retinectomy is being done. And after this retinectomy is done, you will find that you get access to this subretinal membrane, which has been removed. And then you find there's another subretinal membrane adjacent to that. And this was accessed and removed. And after this is removed, you put PFCL further to bring it to the level of the retinectomy, see that it settles, and go ahead and do laser and complete your surgery. Yeah. Now, what about retinectomy for retinal shortening? There are, as I said, two situations. You've done a complete removal. The first situation is you could not complete removal of all retinal surface membranes up to the ora, and you felt this would prevent the retina from settling. The second one is there is a failure of retina attachment even after central and peripheral epiretinal membrane peeling. So this is a stiff retina with retinal shortening. First, you confirm the failure of the retina to settle even with PFCL. Ensure removal of the retinal surface membranes at least till the point from which the retinectomy is planned, and then you do your retinectomy beyond the area where you've done complete membrane removal. So you see over here, this was a patient in whom these membranes were being removed, vitrectomy is being done, and they tried to remove these peripheral membranes and found it very sticky. They're having difficulty in removing it. So put PFCL to check whether there are any membranes at the retinal surface near the posterior pole. Couldn't remove anymore. Again, tried to remove the peripheral membranes and is finding difficulty in removing these membranes. And finally decided to do a retinectomy to settle this. And you can see there are some radial folds over there, which after doing the retinectomy, and this retinectomy must be beyond the level where you think that there is shortening. So you must go beyond that, and then when you do the PFCL, it should flatten the retinectomy. If it's not, it means there's a membrane there and that is being cut over here. Now you've seen it settle down completely. And then you go ahead and do the laser and complete the surgery. Now, the other important thing is you can see there's a direct silicone oil PFCL exchange. Whenever your retinectomy is more than 180 degrees, it's preferable to do a direct exchange to prevent slippage. And the other important thing is when you do a direct PFCL silicone oil exchange, put your cannula at the tip of the PFCL, not at the bottom of the PFCL. Otherwise, you may get a premature removal of PFCL and then you'll get a slippage. So the important thing is you'll see the dimpling of the PFCL. Leave the extrusion needle at that level. Let the silicone oil come slowly down. Maintain yourself with that little dimple only, so that in the end, you know, there's only a little bit of PFCL left and there's no fluid over there. Now, the fact is that retinectomy for complex retinal detachments can help salvage the retina and provide useful vision in many cases. There is, however, a risk of reproliferation and hypotony. And hypotony is very common in the post-operative period. However, it's a useful tool for desperate cases. At the same time, let me tell you, this is not a preferred technique for me. It's not a procedure of choice for me, except when all these alternatives fail. And what are these alternatives? First, I will make an effort to remove all the membranes possible. I will not hesitate to spend an extra 45 minutes even to remove these membranes. I will do an ILM peeling till the periphery. And if I suspect that there is likely to be shortening, I may place the buckle. And we're not talking of a band, we're talking of a 276 buckle in the area of maximum shortening, because that also takes away the effect of shortening. Only if these things fail, then I consider doing a retinectomy. That's why I must thank my colleague, Dr. Ritesh Nirula, for giving me these videos, because I personally do retinectomies very rarely, only if I find everything fails. And that is the basic message that I would like to give. People are in a hurry to finish surgery. Take your time, remove the membranes, and you will find many of these cases will settle. Thank you very much, Lady Linda. You muted? I can't hear.
Hello?
Yeah. Now.
Thank you, Dr. Talwar, for your nice presentation and videos. You give a good insight to retinectomies. We can discuss any comments later on. Now Dr. Salam. Dr. Salam is an associate professor of retina and uveitis, director of uveitis service in Jones Eye Institute, USA. Would you please, Dr. Salam, share your screen?
Yes, thank you so much. And I enjoyed Dr. Talwar's presentation so much. Okay, so I chose to, again, like Dr. Fayyad, I like the discussion, so I'll very much abide by the time. And I choose to go into something which involved the PFCL oil exchange. I like the fluid exchange, and I think it's a very interesting area. And along the case, I'll tell you what I tend to do. So there's a patient with a total PVR detachment and came very late to us, which is very unusual. I came like 2 months after retinal detachment. He was very like laid back. Oh, I lost my vision and I decided to come now 2 months after. Had cataract. Usually we don't remove the cataract unless the cataract is dense to affect the view. And then this is the retina now. He has what looks like more of a giant break there with PVR and pigments. So what I tend to do with PVR detachment is we do a vitrectomy with indentation and try to remove most of the vitreous. Usually with primary detachment, I do not do that. I'm not very aggressive with vitrectomy, and all what I want is relax the tears and remove as most vitreous as I can, but I'm not very aggressive with vitreous shaving. With PVR, I'm slightly more aggressive and I try to remove most of the vitreous. So here, and then we stain with blue, and mainly to see if there are PVR membranes. And we really looked and we didn't find anything to peel. So we decided, okay, to deal with that area, and it was so curled, then we went for a retinectomy. So me, buccal versus retinectomy. So for PVR, I start by peeling posterior to anterior if there's anything to peel. I usually don't peel the ILM unless it's part of the epiretinal membrane, and I would peel it. Then if the shortening is small, then I would put a buckle, and that's usually encirclement. If the shortening is more than small and there's extensive shortening and stiff retina, especially near the breaks, then we go for a retinectomy. And once we decide a retinectomy, there's nothing called a small retinectomy, in my view, and I always go into a big retinectomy, smiling into a healthy retina, like this. And we use the shaved mode of the cutter, which is really nice. It acts like a scissor. And then after that, we go for the cutting mode and remove the anterior flap and then laser. And very important, especially for the young people seeing us, is to understand what happens at the horns of a retinectomy or a giant retinal break. So the PFCL may not reach well, so you may not be able to laser well. So you have two options. One is to fill more, or you have several options, fill more and add laser with indentation. Or the other option, if you are going to go to air, then oil, then you can laser under air. It will be flat if the retina does not slip, or you can use cryo to that area, or you can complete that part under oil. But just be wary that the horns are an issue in giant retinal tear and retinectomy, and you really need to laser them well. So we added PFCL laser that, and this is a technique we've been using for the PFCL oil direct exchange the passive way. The problem with that exchange is the PFCL removal is inefficient. So usually you end up with high pressure in the vitreous cavity, and you can have problems even with oil coming to the front of the eye, and I've seen a case where the eye burst. So we tried to mismatch the removal of PFCL with the oil by giving the PFCL more advantage, using a wider gauge cannula like we do here. So we changed that to a 23 or a 20 and use that for the passive PFCL removal. If you change a 25 to 23, here we prime the oil. If you change the 25 to 23, you get 1.5 more times removal. If you change a 25 to a 20, you get 2 times quicker removal, which means like less high risk of pressure rise in the eye. And then we go to the break, we wait there until the oil comes in. The important thing, the tip needs always to be in BSS or PFCL, not oil. And once the bubble comes in, we go and check on the brakes, and then we move to the disc. And you see the disc in this case doesn't go really white as you see in the passive exchange, and the vessels do not get much attenuated. So it's a nice way of doing it. And then you just follow the bubble and it finishes. And then we tend to suture all ports in oil. And the patient was attached here, and we thought he had PFCL under the retina, but that was a bubble of PFCL over the retina in the concavity of the retina here. And thank you so much.
Nice presentation and technique, Dr. Salam. Thank you very much. Any comment from the panelists, Dr. Talwar, Dr. Faisal, Dr. Wahib?
Yes, I have a comment. Ahmad, a great presentation. Thank you very much. Always informative, very elegant and nice. But I would do maybe differently. I would not go right away to retinectomy. I would peel and peel. Maybe I'm used to stay inside the eye for more than 3-4 hours. I have no idea. It is.
But what would you peel? I thought the edges really, like the edges are so curled. What would you peel? You peel more at the edges. We couldn't find anything posterior to peel.
Yes,
we stayed there. I mean,
maybe I find some membranes. The other
at
thing,
the edges,
in such cases where I do retinectomy or there is PVR, I always peel the ILM. Always.
Yes.
Always peel the ILM. Every time that I did not peel the ILM, I was always punished. There is always posterior PVR, recurrent posterior PVR. This is what I do. Otherwise, I would do the same. Absolutely.
You know, actually, when you see these rolled edges, it looks as if they may have thick membranes. Most of the times, if you take your PFCL to the edge of the membrane and use a diamond dusted scratcher, These are very immature membranes, and you'll find you're able to straighten out the retina in most of these cases. It's very rare that it doesn't straighten out. If it doesn't straighten out the edge, you may diathermize and cut out the edge, only the edge. You don't need to make extensive retinectomies beyond the giant retinal tear, most of the times, unless there is actual star folds or some kind of membranes forming over there. Most of the times it works. And as you know, as you were just told about, if there's any doubt, ILM peeling is a great technique, but very often you won't need it. Not in a giant retinal tear. Usually giant retinal tears are relatively early presenters. They don't take, they're not the kind of things which are going to be there for 3 months and all, and then they present. They come much faster. The other important thing is, I mean, you showed a very great job about the silicone oil PFCL exchange. I use the same technique. I use passive exchange only. And as I said, I put it just at the level of the tip of the PFCL, which is at the same level, the BSS oblique the PFCL. The important thing is you see the disc underneath so that you never get increased pressure. So if you can see the disc underneath, the moment you know the pressure, the pressure is going up, the disc will start pulsating even before it becomes pale. Stop. Because it's in PFCL, it will drain off again. It just needs a little more time as compared to, but I will never do active suction. You see, active suction has a tendency to cause quick removal of the PFCL before the silicone oil has reached that level. So I would do exactly what you're doing. And usually since I operate with 23 gauge, I don't find this problem. I agree with you. If you're using 25, you have to be careful because the rate of removal of PFCL is slower. So that's absolutely right.
I think these are great points.
Job. I think you've shown a great.
Thank you so much.
Points are well made.
Okay, great points. Thank you for very nice comments. And obviously, we have a lot of options and techniques for these. We have to move on to Dr. Vishali Gupta.
Yes, here.
Hi,
But
Doctor,
I'll be.
Yes.
I'm good. Thank you. Thank you, everyone. So I'll be showing a recorded video and then I'm available for discussion. So can I request my video to be played? Perfect. And I would like to thank Dr. Amri for giving me this wonderful opportunity, as always, to participate in his very interesting meeting. I'm going to share with you all 4 tips in the management, or rather surgical management of angioma. Now, here is a young girl who presented to us with angiomas in both the eyes, and right eye, in addition, had tractional retinal detachment in the lower nasal half, as you can see with the arrow, as well as multiple angiomas elsewhere. Now, before we actually go on to surgery, it's important to examine these patients carefully for their systemic association, because they may have vinyl mandelic acid elevated pheochromocytoma. So if proceeded towards GA without looking at it first, it could cost patient even his or her life also. For example, this patient had cerebellar hemangioblastomas, pancreatic cyst, vinyl mandelic acid was elevated, and BP was kind of fluctuating. Once we have diagnosed this patient, the next very important step here is to examine the siblings. Now, the brother of this girl, who was asymptomatic, as can be seen, had small angiomas, which we can manage at this stage and prevent blindness in the sibling. So this is the second outcome that important to sibling screening. Now, once the diagnosis is made, there are several surgical challenges, but the 2 important ones which we need to tackle are intraoperative bleeding and thick membranes. Now, I'm going to show you the surgical video of this patient where we did put belt buckle and supported the area that had tractional retinal detachment with thick band going and contracted retina. Pars plana vitrectomy, standard 25G, and you can see a core vitrectomy is done. And as you can see, the vitreous is kind of gooey in these patients. So you may have to spend actually some more time to make sure that the vitreous is come out. The bleeding is the major risk. Now, would you just diathermize or leave them? But then the sleeping dogs are not good because they could wake up anytime. So important to just totally remove the angiomas. Now, this is the third important learning lesson is that you expect torrential bleeding. So always keep a good endodiathermy ready, because severe bleeding, once it happens, you may be busy clearing it and you cannot do further surgery. Now you can see one by one, we are disconnecting angiomas by the traction bands, applying a lot of diathermy to it so that it doesn't bleed torrentially, but still there is a tendency. So diathermy is the key. So once you are sure that enough diathermy is done, just eat them away. The next step is, of course, the patient had detachment, so we had to clear all the periphery to make sure there was no traction. And again, it's very important, which is the fourth learning outcome, is the meticulous membrane dissection. Because if we are not, we have to understand that these patients tend to have layer after layer of thick membranes, and like the onion peel. So you may have to be patient, remove a layer, then you may see a second layer, and finally remove the internal limiting membrane so that all these things are taken care of nicely. Now you can see there is a thick band which is going towards the area of traction with a large angioma sitting there. So we remove the membrane. We plan to diathermize and create retinectomy here because this retina needs to relax to go back. So as you can see, a retinectomy is created, fluid gas exchange was done, and finally the endolaser to the retinectomy site. Surgery was ended by filling the eye with silicone oil. And this is the post-op picture of the patient, and the patient has been stable for the last 6 months. So with this, I would like to thank my surgical team, including Dr. Aniruddha Agarwal, and of course, Dr. Amri once again for his very kind opportunity. And I'm happy to discuss it further. Thank you very much.
Thank you, Dr. Gupta, for such a nice presentation. Are you using silicone oil for all such cases?
No, I would not use. Personally, silicone oil is never a first choice for me for anything. I always prefer gas, but in this case, we had a retinectomy, which was inferior, and that's why we prefer to use oil.
But you, as you mentioned, you almost always peel the ILM. So
I'm not always.
Okay, yeah.
Not always, but this one, like in VHL, I have an experience of doing it in quite a few patients. The problem is vitreous comes in layers. So there is not a single kind of a vitreous cases. You remove a membrane, then something stains, then you remove the other one. So it's kind of adherent and multiple layered. So to make sure that everything is removed, I do stain ILM and I do peel ILM in complicated cases like this. But if it is a single straightforward case with not much of the contraction of the retina, I would not always peel ILM. But still, I would make sure that everything anterior to ILM is peeled off. Because these are the cases where vitreous sometimes, just...
Any of the respected panelists has some experience with such rare cases of hemangiomas? How to deal with the intraocular bleeding?
I did a few cases. I did a few cases, but I mean, I have no idea. But I never used the buckle in such cases. I never used the band, the scleral band. I have no idea. Maybe Dr. Gupta did more than me, and she has more experience in this pathology. But me personally, I never used scleral band. Once I have to remove angiomas from a new growth over the surface of the retina, because it's not question, but there is no traction. I mean, it is internal, just bands and whatsoever. It's not PVR problem. I have no idea if Dr. Gupta can comment on that.
I think, Vaishali, if you were not doing a retinectomy, then the band is more important. But if you decided to do a retinectomy of that entire area, then the need for the band and buckle goes away. So in fact, that's what I thought, that maybe you will support that area of the traction detachment with the band, and that's why you decided to put the band and buckle.
Also, sometimes. Okay, go ahead, Dr.
The other thing I'd like to ask you is, what if the membranes are very sticky? Sometimes they're very sticky quite posteriorly. Now, would you use bimanual removal as a method, or would you do a retinectomy posteriorly in that situation? Or would you prefer to leave it with a buckle only without removing the traction?
You know, it will depend on how stiff the retina is. If the retina is not very stiff, I would like to have some patience and remove them layer by layer. As you said, they are very sticky. So you inject triamcinolone, you feel the membrane has come off. But if you inject triamcinolone again and you realize there is still something more. So I would use diamond dusted a lot here to peel off those membranes and take them to the edge. And then I will do the peripheral dissection. So even if I have a little bit of skirt left between the posterior pole and the anterior most part, which is not attached to anything, I would leave it and support it with buckle, maybe. The second part is the retina is very stiff and I feel I have to do retinectomy. So that is why where the complete retinectomy will be done. And if I tell you genuinely, in this patient, when I started, I did not have a plan to do retinectomy. I thought I will be able to support this angioma,
That's what I thought.
Yeah, but the kind of retina was short and contracted, so I had to change the plan.
Yeah.
Okay.
And it's a little scary because sometimes it can be an extensive retinectomy, and then you're worried whether that fold will settle back or not. You were lucky, it settled well.
And I did not want to cryo the angioma in the periphery, so I just diathermized and cut.
I can see my friend Dr. Al-Khashab joined now. Hi, Ahmed, how are you? Nice to see you.
Fine, Mohammed. I'm so sorry about not being from the start. I had an emergency retinal detachment macula on. So the duty for the patients is always
comes first.
Yeah, first.
Thank you for joining, Ahmed. Would you please share your screen right now?
Yes. Yeah.
Thank you.
Okay.
Great.
So I have like two or a couple of brief cases. This is a 42 years old male patient. He had non-medical history. Visual acuity at presentation was counting finger 2 meters. And the history is that he had a retinal detachment, superior 2 tears. And for that, he did pneumatic retinopexy 2 weeks earlier in another hospital. By examination, there was some cataract, posterior subcapsular cataract and retinal detachment with inferior giant tear and epiretinal membrane and PVR. So this is the image at presentation. And this is the OCT. The macula was still on, partially off. I think during the surgery, it was totally off. So the presentation, you can see even the gas bubble that was remnant. I usually start anterior vitrectomy to remove all the vitreous and remove the remnants of the gas. And you can see that the giant tear inferiorly with multiple small tears circumferentially, which can happen with the pneumatic retinopexy. Whenever we have the gas bubble that is moving inside, the vitreous can pull in opposite direction. There was positive PVD, and I did not need to create a PVD, but to remove the vitreous skirt peripherally. Just to join these two small holes with the giant tear, removing the anterior retina to prevent any further proliferation later on. And then to tackle any PVR or epiretinal membrane, so I used the dual membrane blue to stain. And we can see here the membrane that was stained well. And I usually peel these membranes with ILM forceps and extending the peel. In such cases, usually it comes with the ILM all in one part, but sometimes I will double stain again to make sure that the ILM was peeled properly. Sorry for the high magnification. There was some issue with the camera, but that's the peel of the epiretinal membrane. And I think it is with the ILM as well. And this comes with the texture of this membrane. We can see even the extension here of the epiretinal membrane and the ILM. I can move here. And then PFCL, I prefer, if I can do the membrane peel and the ILM peel without the PFCL, I feel that at least to start the peel is very important without the PFCL. Maybe after starting the peel, maybe I would put the PFCL if I felt that I'm causing excessive traction on the retina, and then making sure to dry up the retina totally, clean up the anterior vitreous, clean up the anterior flap of the retina, then silicone oil PFCL exchange. And this is the image post-op. There was some cystic changes in the macula. And this is, I think, 1 week post-op. I expect this to go away totally on its own. Sometimes it may need an injection of Ozurdex, but the vision improved in this patient to 20/40, corrected with +4 after the surgery, 2 weeks after the surgery. This is actually a patient, a diabetic patient, but she had a recurrence of traction retinal ligmatogenic retinal detachment after 2 failed surgeries done elsewhere. And this was the image at presentation. So not just the TRD, but PVR as well. So whenever there is a traction with this diabetic patients, usually I prefer to use bimanual technique, not to cause excessive traction on this fragile retina. So we can see that this is actually a PVR rather than a diabetic membrane that has caused this point of tear, and through which the retina was detached. But unfortunately, when I've seen the patient, I wasn't able to see that there was as well a macular hole. And for the macular hole that was there, I did staining again, and I found out that the ILM was totally peeled all around with a large peel. I tried to mobilize some ILM flap from one part and move it to cover this this macular hole, and it was large macular hole, but I wasn't able to do that. So I put PFCL to stabilize the retina and start to grasp another ILM flap and try to do the same. But I wasn't able to do that. So I eventually did a free flap and multiple free flaps that I took and I put them inside this macular hole. I'm moving it a bit fast. I know we are a bit late. So I tried to fashion the flap and to mobilize it. I failed, but anyway, now I have a good flap that I was able to harvest and put in the macular hole, making sure that it is covering the hole totally. And this is the post-op image, immediate post-op image under silicone oil. And this is after removal of the silicone oil. This is even the fluorescein, the OCT angiography, and this patient improved to 20/40, as I remember. This is another patient with macular, large macular hole with retinal detachment. So the plan was to do an ILM flap as well. So dealing with retinal detachment as normal. And then
Mr. Ahmed, we have only 1 minute for the whole session.
Okay.
Very
Okay, so-
elegant surgery. Thank
you
you
so
very much. Thank
I'll
you
stop
very
sharing.
much. Thank you very much, sorry for this. I would like quickly to thank everybody for this very nice session. We came to an end, and hopefully to see you in other surgical sessions in this nice meeting, inshallah. Thank you, everybody. Thank you very much. Appreciate
Thanks a lot.
your presence and your talks. Thank you very much. See you. Thank you.